I have a great pleasure of hosting Dr. John Krystal, who is one of the experts in psychiatry and psychology. So, Dr. Krystal, thank you so much for your time and for being here.
My pleasure. Good to be with you today.
Thank you. Okay, so I would like to start with questions on depression, since it's a very common issue these days. So, how can we define depressive disorder, and is depression the most common mental disorder nowadays?
Depression is an extremely common problem for people, and it's a very heterogeneous condition. At this point, about 1 in 5 people at some point in their life will experience symptoms, problems that will meet the criteria for depression, even though they may meet criteria for other psychiatric disorders as well. But so right now, it's about 300 million people in the world suffer from depression. Yeah. So what is depression? I think it's good to think about depression as a syndrome.
Mm-hmm.
And so we think of depressed mood, sad mood. And people can feel very intensely sad and depressed, but they also may experience a constriction of their mood. In other words, they may feel very flat, as if their mood doesn't react to things,
Right.
almost emotionally dead in a way. They may experience a loss of appetite and weight loss, or they may find that they're eating too much. They may feel like they can't sleep at night, or they may find that they feel tired all the time and they're sleeping more than usual.
Right.
They may feel like they have no energy, or they may be so agitated and anxious that they can't relax.
Right.
They may find that they have trouble focusing their concentration and staying focused on what they want to think about. Or they might find themselves locked into kind of thinking about the same negative thoughts over and over and over and over again. I mentioned they may feel very flat and unreactive to what's going on around them. But some people will find that their mood is very changeable and labile, and that they can't tolerate any stress in their life without getting a very strong emotional reaction. So as you can see, in depression, you may have opposite symptoms. No energy, agitation, no sleep, lots of sleep, etc. But this broad constellation still falls under depression because of the hallmark of depressed mood, lack of pleasure, that's called anhedonia, which is a prominent part, and also the energy, metabolism, symptoms, and cognitive aspect.
Right. Why are we seeing its increase lately, especially among young people?
Well, I think that for everybody, the pandemic has been an extremely difficult time. And there are many aspects to it. But one of the ways that people cope with stress is through getting together and being supported by their friends, colleagues, family. And during COVID, people were more isolated.
Right.
And that really sets people up to be vulnerable to stress. And we know that there were a lot of stresses during COVID. One was just the fear of getting ill. The second for young people was the disruption of their educations, which was really, for many people, they effectively lost a year or even 2 years of their schooling and have so much to do to catch up. A third one is, which sort of was exacerbated during COVID, but which persists, is the inordinate kind of social stress in our society. A lot of social and political turmoil, and that affects everybody.
Right.
And then we know, in addition, during the pandemic, a lot of people died, and that means a lot of bereavement. And bereavement, losing social connections, and the bereavement process is one of the triggers for depression in a lot of people. So a lot's going on, and young people were particularly affected, I think.
Right. What are the differences between depression and other mental health disorders, such as anxiety and bipolar disorder?
Yeah. Well, one of the things that can be complicated about drawing clear lines between depression, bipolar disorder, and anxiety is they often occur together.
Right.
And one of the more common forms of bipolar disorder is what we call bipolar depression. And I'll explain a little bit about the differences. So when we think of anxiety disorders, there are different forms of anxiety. And each of these forms of anxiety may occur in the context of depression or bipolar disorder.
Right.
So when I'm talking now about these anxiety disorders, I'm talking about when the person is not depressed and does not have bipolar disorder. Okay? So one kind of anxiety is called generalized anxiety. And that's when you get up in the morning and you feel anxious and uncomfortable, and that feeling sticks with you all day. And it doesn't necessarily get worse or get better during the day, but it's a relatively steady kind of oppressive burden that you carry with you during the day. And what's interesting about generalized anxiety disorder from a medication point of view is that there are some medications that tend not to work for other anxiety disorders or depression, but do work for generalized anxiety disorder. And that one of the medications is called buspirone, or Buspar. Another kind of anxiety is anxiety that comes on like a wave, where you feel like your heart is pounding and you're sweating and your gut is constricting, and oftentimes, and we call these waves of anxiety that come and go, we call them panic attacks.
Right.
And oftentimes, until people recognize what's going on, when people have panic attacks, particularly when they first start out, they may worry that they're having a heart attack. They may worry that they're having an asthma attack, or something is wrong with their intestines, or some other problem. And so a lot of people who are in the early stages of recognizing that they have panic attacks will be getting their treatment in the emergency room instead of from mental health people. And one of the things that sometimes happens for people is they're so preoccupied with the body changes that happen during a panic attack that they may not even appreciate that it's occurring in the context of feeling anxious. In other words, they may think it's just a body syndrome and not a mental symptom. So for some people, they have to kind of learn the psychological context of panic attacks. So people who have panic attacks learn that their panic attacks tend to occur in specific places, in specific settings. So for example, it might be a crowded room. It might be trapped in elevators. It might be driving in a car. Might be getting on an airplane. You know, so what happens with people is that who have panic attacks is that certain settings are associated, and so even when they are not in the plane, just driving to the airport, even when they're just thinking about getting on a plane, like making an airplane reservation, they can start to anticipate the anxiety. And that we call that kind of anticipation anxiety, like when they're thinking about getting on an elevator or thinking about getting into the car or on the high. We call that a phobia.
Right.
People get afraid of certain situations. So they, some people are just naturally afraid of certain things, spiders, high places, things like that. But particularly people who have panic attacks learn to be afraid of certain situations because they're afraid of the fear of the
Right,
panic
I see.
attack, right? So fear of the fear,
Mhm.
and so and psychological trauma,
Yeah.
right? When people are afraid of something real, like a psychological trauma, afraid of being assaulted, after having been assaulted or in a car accident or something bad has happened, we call that post-traumatic stress disorder.
Right. Yeah. Yeah.
When the trauma is the panic attack, we
Mhm.
call that panic attack with agoraphobia.
Mhm.
And one of the big problems there is that when people learn to anticipate situations where they are going to feel anxious,
Yes.
is they start avoiding those situations.
Yeah.
And so their world gets more and more and more constricted. Okay? So those are basically the anxiety disorders, which are highly comorbid, in other words, commonly occur with depression and bipolar. We talked already about major depression, so let's draw the distinction with bipolar disorder. Now, people also know bipolar disorder, as you know, by another name, manic depressive illness.
Right.
Right, and that means that and that's they often think that there's a little switch in your head, like the light switch in this room, that transitions you from healthy to depressed to manic. But it's much more complicated, and it, just as in depression, where we talked about how people felt, in other words, their mood, how people behaved, in other words, their activity, and how they thought. What has been described for bipolar disorder is like a menu, so that you can have mania being an hyperactivated, euphoric, irritable state,
Yeah.
and depression being the kind of shut down state that we talked about. You can have a mixture of these states. In other words, you could be very irritable, but you could have no energy, and you could have very negative thoughts. In other words, you could have the kind of mood changeability, reactivity that we associate with mania with the other states. But with mania, we think of activated states, reduced sleep, impulsive behavior, irritability, grandiosity, impulsivity in many spheres, like sexually impulsive, risk-taking, and kind of loosening of association, increased rate of speech, increased kind of maybe even psychosis, in other words, delusions and hallucinations. And one of the reasons that we call it manic depressive illness is that people do cycle. In other words, they may have periods of some people cycle as rapidly as within a day or 2 days between mania and depression and mania. But other people will cycle over many years very, very slowly. They may spend 2 or 3 years depressed or hypomanic. Hypomanic meaning you're a little bit hyperactive, you're talking a little too fast, you're a little bit impulsive, but not so bad that it's destroying your life. With mania, the activity, the flight of ideas, the impulsive behavior, the bad judgment is often extremely destructive. People having sexual affairs outside of their marriage, people spending money that they don't have because they are feeling so euphoric or impulsive, people getting into fights or other kinds of things. So um, uh, uh, it can be terribly destructive. One of the things about mania and manic depressive illness is that many of the things that we think of as being destructive of psychiatric disorders in terms of complications commonly occur with mania. So, for example, mania is the disorder of all the psychiatric disorders associated with the most completed suicide attempts. It's also a disorder that is very commonly associated with substance use disorders. In other words, when people are feeling very irritable and activated or euphoric, they tend to use more substances. Sometimes they use them to help dampen the euphoria or activation. Sometimes they use it to augment those feelings. And so one of the critical things when it comes to treatment is that we use different medications for manic depressive illness, bipolar disorder, major depression, and some of the anxiety disorders. So for most of the anxiety disorders and for the major depression, the most common medications are the Prozac-like drugs, the SSRIs, we call them, or SNRIs, which is a cousin of the SSRIs. These are antidepressant medications. They tend to take about a month to start having their effect, and they tend to help, for those people that they're going to help, they tend to kind of kick in over about 2 months. We, even though they're the most commonly prescribed medications for depression and anxiety problems, we tend not to prescribe them for people who have bipolar disorder because the SSRIs can trigger people switching in between the mood states. In other words, you're prescribing an antidepressant for someone who's feeling depressed, but if you give them an SSRI, you may trigger a manic episode, and we don't want that. Sometimes the only way to get someone with bipolar disorder and depression better is to prescribe an SSRI, but overall they don't work very well, and they carry the risk. So when a person with bipolar disorder is depressed, we tend these days to use different kinds of medications. A very commonly prescribed medication for bipolar depression is an anticonvulsant medication called lamotrigine or Lamictal. Another kind of medication that sometimes can be prescribed is bupropion, which is a regular antidepressant that seems to have a little bit less tendency to trigger mania. Another class of medications that can be prescribed for bipolar depression are things like, we call them atypical antipsychotic medications. Medications like risperidone, quetiapine, aripiprazole, et cetera, et cetera, et cetera, et cetera. Lumateperone, blah, blah, blah. Vareprozine. And then for depression, there are neurostimulation treatments like transcranial magnetic stimulation, which involves putting a magnet over a part of the brain and having sessions of stimulating the brain magnetically. The magnetic stimulation causes an electrical activation of the brain underneath. And then there's very well known what in many ways is the gold standard treatment for treatment-resistant mood symptoms, and it works for mania and for depression, is electroconvulsive therapy, or ECT. Now, a kind of treatment that I have been involved in studying involves an anesthetic drug called ketamine, or its FDA-approved version, which is for treatment-resistant symptoms of depression, which is called esketamine or Spravato.
Mhm.
And it is a fundamentally different kind of antidepressant
Right.
from the standard SSRI medications. So with the standard antidepressant medications, as I say, you have to take it every day,
Mhm.
sometimes for a few months before you start to really feel better if you're going to respond to it.
Mhm.
And what's remarkable, and what's, let me just say, as helpful as these medications are, we know that for many patients, perhaps as many as half of patients, this medication, the SSRIs, are really not going to help them. And so we needed to develop treatments for treatment-resistant symptoms of depression. And the most common approach is to add an antipsychotic medication. And there are a number of options there, and that's helpful. But esketamine or ketamine can get people in many cases, within a day or a week or two, as much improved as they would have gotten over several months of treatment. Right. And in patients who have really treatment-resistant symptoms, when you add another standard treatment, you tend to get 10 or 20% clinical response. When you add esketamine instead, you tend to get more like 50 to 75% response. Hugely more effective. And what's interesting is that esketamine, is about twice, when you get esketamine, you're about twice as likely to get better than when you add, say, an antipsychotic medication. And I would say one other thing is that one of the challenges that you have in treating depression or in getting treated for depression is that sometimes you can be on a medication, and for reasons that are not at all clear, you've been taking the medication every day, everything the same, it stops working. Right. We call that relapse. And if you have treatment-resistant depression, meaning that they've tried a medication, it didn't work very well, another medication was added, or you switched to another medication, that didn't really work that well, and then you finally got better. If you got there on with standard medications, over the subsequent year, you have about a 75% chance of relapsing. Yeah. And somewhere between a 50 and 75% chance. In the long-term esketamine study, that relapse rate was only 25%. So not only did the esketamine get you better quicker, not only did it work more effectively, but it also protected against relapse. And recently, Janssen Pharmaceuticals shared some long-term, Johnson & Johnson shared some long-term data that I thought were really very striking, which is that they studied people, over 1,000 people who had been treated with esketamine on average for 42 months of treatment. Okay. That's almost 4 years. Yeah. And they found that compared to standard treatment data that they referenced their results to, that over those 4 years, esketamine produced about a 10-fold reduction in suicide attempts compared to standard treatments. And we know these standard treatments are pretty good to begin with in reducing suicide attempts. Reducing suicide attempts. It produced a 5-fold reduction, or about 5-fold, maybe larger, reduction in dying by suicide. In other words, successful suicide attempts. And about a 3-fold reduction in all-cause mortality. So what's all-cause mortality? When you have depression, and if you don't treat that depression, depression is so stressful for the body that it worsens nearly every medical condition. It increases the chances of dying by heart disease, by respiratory disease, by kidney disease, et cetera, et cetera. And so people who have inadequately treated depression have about a 10-year shorter lifespan. But if you, and it's probably the case that if you treat depression with standard medications, you extend, you reduce that shortening of life expectancy. But with S-ketamine, you you restore life expectancy to an even greater extent, and that's why you get that change. So you have this array of treatments for bipolar disorder: lithium, mood stabilizing anticonvulsant medications, atypical antipsychotics. These medications tend not to be used that commonly for the non-bipolar depressions, but there are the antipsychotic medications, yes, lithium not so much, lamictal not so much, but they do have some beneficial effects in very refractory patients.
You mentioned stress several times.
Yes.
So can stress lead to some kind of mental illness?
You know, it's said in the PTSD literature that everybody has their breaking point.
Right.
Right, which is that people, no matter how resilient, can deal with so much in their life that it can make them feel depressed.
Right.
And what's interesting is that depression, major depressive disorder, is about 40% genetic.
Oh, okay.
And what is that 40%? In other words, what is it likely that this 40% is? These are probably factors that help us to cope with stress in our life or help us to bounce back from stress when we have it. And but 60% is our environment, the stresses that we face, the level of social support. Remember we said, why are all these young people getting depressed? It's because environmental stresses are such a big factor in developing stresses. It turns out that if people do not have a strong genetic vulnerability to depression, then almost all of those people have severe stress in the context of their first episodes of depression. But there are some people who are highly vulnerable, highly genetic. Maybe they have an identical twin who's depressed, or all the other members of their family are depressed. These people may or may not have a major life event. It may be that just the normal stresses that we all experience in our lives, for some people, are enough to trigger a depression episode.
How can we define PTSD, and what can lead to developing PTSD?
Yeah. Well, I think that the major difference between PTSD and stress-related depression and stress-related anxiety is what we call, because of the diagnostic manual, DSM-5, a category A life event. And what we mean by that is that either you think you're going to die, or you're witnessing someone who you think is going to die, or some other really extraordinary event where you're really questioning your safety, even if it's a symbolic threat to your existence. And without that, you can't have post-traumatic stress disorder without a trauma, without a trauma. Post-traumatic stress disorder is often thought of as a fear disorder because something bad happens and you are very aroused, you can't relax, your reminders of the trauma are very stressful. All of those aspects of post-traumatic stress disorder are very similar to what I was saying about panic disorder and agoraphobia. But there are other parts to post-traumatic stress disorder that can be very distressing for people.
Mm-hmm.
For example, depression like negative emotional states.
Mm-hmm.
And what's interesting is when people have more severe PTSD, they almost always score highly on depression rating scales.
Mm-hmm.
Whether that kind of depression is the same as the kind of depression that people have who don't have a trauma in their life remains to be seen. And we know that the responses to treatment are a little different in post-traumatic stress disorder and major depression.
Mm-hmm.
Themes of vulnerability, sometimes shame or guilt, or guilt sometimes related to how did you survive,
Yes.
but other people around you didn't survive. Maybe you felt like there were people that even if you couldn't save them, maybe you could have reduced their suffering in some way or something. So post-traumatic stress disorder in real life is a very complicated clinical syndrome, but it does all emerge from the trauma exposure.
Right. What are the current treatment options for PTSD?
Yeah. So we can think of treatment options in PTSD at many levels. We can think of psychological treatments, psychotherapies, and so there are several forms of cognitive behavioral therapy, progressive exposure, cognitive processing therapy, EMDR, eye movement,
right,
et cetera, desensitization and relaxation, and there are other kind of CBT trauma-focused psychotherapies. There are, and then there are medications.
Yes.
There are 2 FDA-approved medications, one called Zoloft or sertraline, the other called Paxil or paroxetine, and there are all the SSRIs and SNRIs that are commonly prescribed.
Right.
And that's as far as the FDA kind of approved treatments for PTSD. What you find is that these medications work for some people, particularly people relatively early in the course of their PTSD, particularly people who had relatively few traumas. And that in people with chronic PTSD, it's a bit of an exploration of doctor and patient trying medications that seem to target the symptoms that a person presents with. In other words, if a person can't sleep, then insomnia medications are tried. If a person can't sleep, then cognitive behavioral therapy targeting insomnia and improvement in sleep hygiene might also be tried. If a person is very paranoid, feels very unsafe, then maybe an antipsychotic medication would be tried to tone down that feeling of vulnerability and insecurity, and so on and so on. So what you often see, despite limited guidance from definitive clinical trials, is that a person with long-standing chronic severe PTSD might be treated with 3 or 4 medications, psychiatric medications. One other classic symptom of PTSD that I didn't mention is called a flashback, where people not only have intrusive memories of the trauma, but actually feel like they're reliving it, as if they are in the movie that's being replayed of the event. And flashbacks are a special case of a broader set of symptoms that you sometimes see in severe panic attacks or in PTSD, which is what we call dissociation, feeling spaced out, feeling like things aren't real, feeling like time is slowed down, feeling like your body is in some way altered or distorted, et cetera, et cetera. These kinds of feelings of unreality. It's not every patient with PTSD, but you do see it in PTSD.
I see. What are some long-term effects if PTSD is left untreated?
Yeah. Well, I think untreated psychiatric disorders, any of the ones that I've mentioned, um, anxiety disorders, depression, bipolar, PTSD, all of these conditions take a toll on your body. All of these conditions may disrupt your social relationships.
Right.
You may find yourself getting more isolated. All of these conditions can make it impossible for you to work, so you become disabled or unemployed if inadequately treated. All of these conditions increase your vulnerability to substance use and self-administration of things that you hope are going to make you feel better.
Yeah.
All these things increase your risk of self-harm and suicide. Bipolar disorder, PTSD, some people will be very irritable and may be inclined to violence a little bit for different reasons. With PTSD, there's a kind of a tendency for things to trigger that kind of defensive reaction.
Right.
So that people are already engaged before they realized in protecting themselves from threats that may not be even real. In other words, intended dangers or things like that. So people with PTSD may lose their job because they get angry or too easily at work. So all these complications from untreated conditions have one big message, which is if you're suffering from any of these conditions, get help.
Right.
Because we have treatments that are helpful and can reduce they can reduce not only your bad experiences that you're having, but they can also help to prevent these conditions from having a bad impact on your overall life. With PTSD, for example, in marriages, PTSD can be associated with pulling away from your partner. PTSD can be associated with more aggression, more anger. That can be a problem in marital relationships. In PTSD, you sometimes get, one of the problems in PTSD is that some of the nightmares that people have during sleep with PTSD occur outside of REM sleep. In REM sleep, if you have a bad dream, your body is paralyzed, so you don't move. But if you have a bad dream outside of REM sleep, then you thrash around a lot, and people with PTSD may unintentionally hit or injure their partners without even knowing that it's happening. And so there are so many ways that untreated or inadequately treated conditions like these snowball into bigger and bigger problems the longer and longer they remain untreated.
Right. And what is schizophrenia and how is it diagnosed?
So let's talk about psychosis.
Yeah.
So psychosis is a term we use to describe the inability to differentiate reality from unreality. And the hallmarks of psychosis for psychiatry are hallucinations, having sensations without cause, in other words, hearing voices with no one talking to you, feeling things happening to your body without anything doing that.
Right.
And delusions. Delusions are strong, fixed, false beliefs, and that seem real. In other words, you come to believe that maybe you're being investigated by the CIA.
Yeah, like John Nash did.
Like John Nash.
John Nash, yeah.
Exactly.
Yeah.
And the thing is, we live in such a complicated world. Some of these very scary ideas might seem a little bit plausible, but a person who has a delusion has a fixed belief that it's unassailable belief about that, and act often on the voices that they hear or the beliefs. Now, and I contrast psychosis to delirium. So delirium, let's say you have a really bad fever
Mhm.
and you become delirious. You don't know what day it is. You don't know who you are. Psychosis is you're still yourself, but you can't draw a line between reality and unreality. And all of these conditions, extremely severe panic disorder, severe psychotic depression,
Right.
psychotic bipolar disorder, psychotic PTSD, can at their worst moments be patients can be just as psychotic as a disorder that is primarily a psychotic disorder.
I see.
So what differentiates schizophrenia from bipolar disorder are the presence of these psychotic symptoms, positive symptoms, the negative symptoms, amotivation, asociality, um, impoverishment of kind of emotional interaction, and cognitive impairments, even in the absence of a mood symptom or anxiety symptom or a trauma symptom or other symptoms. And so there's no symptom that's unique to one condition or the other. And so we make these differentiations based on the overall profile, with schizophrenia being this disorder that's primarily focused around the cognitive social psychosis without being driven by a powerful mood state. Bipolar disorder with the mania plus the depression and other symptoms, irritability and activation. Depression, the depression part without the bipolar disorder, without the mania, without that part, and the anxiety disorders um, um, without the depression, more the focus on the panic. So you can think of these as in some ways related to each other and in some ways distinctive. And one way that they're related is that you heard me say sometimes in severe psychotic anxiety disorders, people will receive antipsychotic medications. In psychotic or treatment-resistant depression, sometimes people receive antipsychotic medications. In bipolar disorder, patients are commonly treated with antipsychotic medications. Well, the condition for which these antipsychotic medications were developed was schizophrenia.
I see.
Right? And in schizophrenia, antipsychotic medications are the primary medication used to treat schizophrenia. And the first antipsychotic medication discovered in 1951,
Okay.
this same class of medications is still what we use today, predominantly to treat schizophrenia. And like the other classes of medication, the other treatments, they help a lot of people. None of these medications cure the disorder, although people can go into remission. But if you take the medications, it can certainly mute for many, many people the voices and the thoughts and help people to resume their lives in very constructive ways. What we don't have as effectively for schizophrenia are treatments targeting the cognitive impairments of schizophrenia and the withdrawal part of schizophrenia, which we call the negative symptoms.
Right.
And that's a target of very active research. And there's a medication called CAR-XT, which is the first medication to go to the FDA that does not which is not a member of this class of traditional antipsychotic medications. All the traditional antipsychotic medications have at their core one thing they do, which is that in one part of the brain, it's called the dorsal striatum, it's below the cortex. In that one part of the brain, too much dopamine release is associated with a worsening of psychosis. And so what antipsychotic medications do at the right dose is normalize the stimulation of dopamine receptors in the brain by dopamine. They don't do anything more, they don't do anything less. So if you happen to have a form of psychosis that is not associated with too much dopamine,
Yeah.
you can't expect to get much benefit
Mm.
from the antipsychotic medications. So there are some people who only get partial benefit in terms of psychosis from the antipsychotic medication
See.
because presumably their psychosis is not a simple dopamine psychosis.
Yeah, and what are the most common causes for developing schizophrenia? Is it due to the genetics or so just the environment?
Yeah, that's a great question.
Yeah.
And because schizophrenia and bipolar disorder, of the disorders that we treat commonly in psychiatry, are the most heritable. Both of them, a little bit over 80% heritable.
Yeah.
That means that the majority of the risk for developing these disorders comes from the genetic inheritance.
Yeah.
But even that is a complicated thing.
Mm-hmm.
So, because schizophrenia is still a heterogeneous condition. It's not like there are some diseases where if you have a specific risk gene, then you get the disorder.
Yeah.
There are a number of medical conditions like that. But the closest that we get to is that maybe 1/100th of 1%. Well, that's maybe a little too small, but a vast minority, a tiny minority of people with schizophrenia have a form that comes from a mutation in a single gene.
Oh, okay. See.
So there are some people, and those mutations increase your risk of developing schizophrenia from, say, 10 out of 1,000 to say 500 out of 1,000.
Wow. Yeah.
Okay, or 300 out of 1,000. So that's a very small minority of the overall population of people with schizophrenia. Most people with schizophrenia have what can seem like bad luck, which is that they have an accumulation of risk genes, which by themselves have a tiny impact on developing schizophrenia. So the strongest, so I said the rare mutations, they increase from 10 out of 1,000 to 500 out of 1,000. The strongest impact of an individual common variant risk gene increases your risk of developing schizophrenia from 10 out of 1,000 to something like maybe 14 out of 1,000. So a tiny effect, right? But this cumulative effects of almost 500 common variants that increase your risk for schizophrenia mean that there's a whole spectrum of people that are displaying various combinations of these 500, 450, whatever, probably 500 by now, risk variants that accumulate in different ways to give rise to a syndrome that looks clinically like schizophrenia.
Right. And one final topic.
But let me comment. There are some things that increase environmental factors that increase your risk for schizophrenia. First, in utero, threats to the maternal placental environment, maternal malnutrition, serious maternal infection during pregnancy are two examples. And particularly the second trimester of pregnancy is a little bit of a vulnerable time in terms of that. And that constitutes about 10% of the risk for schizophrenia. And then, so 80% heritable, 10% prenatal. And what about the 10%? The rest of 10%. Well, some of that is severe life stress, isolation, chaos. But one thing in the environment that people do more and more and more is cannabis use, particularly in adolescents and young adults. And that's one of the few things that really has been demonstrated over and over again in different ways to increase the likelihood of developing psychosis, cognitive impairment, and even schizophrenia.
I see. Right. So the final topic.
Sure.
So why is alcoholism such a big issue in our society?
Yeah. Well, I think probably one of the reasons that alcohol is a very common used drug is that our cultures, Western cultures, have evolved to around alcohol use.
Yeah.
You know, there were times when the quality of water was not so good, right? It was very contaminated, and that alcoholic beverages were probably safer than drinking poor water. So people drank it commonly at meals. A lot of religions developed rituals for controlling alcohol use. You use it at this holiday, you have it at that dinner, you have it in this celebration, you drink it at that time. And so alcohol is abundantly available, and it is sanctioned for use in social situations. It's very easy to imagine a dinner party where everybody at the table is having a glass of wine.
Right.
It's much harder to imagine a dinner where everybody at the dinner table is ingesting cannabis. And even harder to imagine a family dinner where everyone at the dinner table is shooting up with heroin. So the availability of alcohol, it's being sanctioned, it's being not terribly expensive, and people learn to use alcohol when they grow up. I can remember that the first year of college, for example, was a time when a lot of college students learned the hard way how to control their alcohol consumption, how to use it constructively in a way that wouldn't be harmful for them. But in that process of experimentation, somewhere between 2 and 10% of the people who try alcohol develop problem drinking. And once you have that, once you develop problem drinking and have that pattern for a long period of time, it can be hard to go back. So some of the problem drinking that people develop grows out of their own propensity to enjoy that feeling of intoxication, to seek it on a regular basis. Oftentimes, it's because other problems, anxiety, depression, bipolar, schizophrenia, or other things, aren't being effectively managed, PTSD. They use it to go to sleep. They use it to help manage anxiety in social situations. They use it to get stimulated, to feel activated, and if you come to rely on alcohol, alcohol can take over. And so all the things that people do commonly, like smoking and drinking, turn out to be the most common addictions. It would not surprise me that cannabis similarly emerges in terms of cannabis use disorder as a growing problem, because any recreational substance that people use commonly ends up having impact in society.
I see. Just a few quick questions. What inspired you to pursue research career in psychiatry and neurobiology?
Yeah. Well, one of the things that inspired me was that when I was in college, I was interested in the problem of opiate use. And I spent the summer after my first year in college working in a clinic at Harvard where I learned about what addiction is, and hearing the life stories of people struggling with addiction, and getting to know people with addiction, and seeing the impact was very moving and inspiring. And I continued to stay involved in that work. And the next summer, I went to London and worked in another opiate program. And when I came back to college that next fall,
Right.
I was taking a biochemistry class. And the teacher said, here's this really interesting story. It turns out that the body makes its own opiate, endorphins and caffeine. And it binds to a specific receptor. And when you give heroin, it binds to that same receptor. So there's a system in the body that accounts for opiate dependence. Right. And it occurred to me, hit me like very powerfully, that these struggles, these life struggles, the problem that these people I was working with, that there were going to be treatments for problems like addiction if we just understood the underlying biology. And I saw addiction as a case of a much broader issue of problems like anxiety, depression, PTSD, schizophrenia. And literally from the moment I learned about that, the opiate receptor, enkephalin, endorphin, that idea, from that moment on, all I wanted to do was to study the neurobiology and treatment of psychiatric disorders. And I've been really lucky that I've been able to make that work.
Right. And the final question, what would you say to young students who are interested in psychiatric research?
So what I would say to young people who are interested in psychiatric research is that this is the single most exciting time in the entire history of the field of psychiatry.
Okay, why is that?
It's because our knowledge of the brain and brain mechanisms is just beginning to be at the point where we will increasingly discover more definitive treatments for psychiatric disorders. So we talked earlier about the genetics of psychiatric disorder, how we have all these genes that increase the risk for schizophrenia, for example. This is all really new information. Right. Our understanding of the brain tissue and the analysis of the expression levels of the various genes and how we translate genetic risk into biology, into circuits, into behavior, into symptoms, into treatment. That process of linking across these levels is just beginning.
I see.
So if somebody is interested in getting into this field, it's just incredibly exciting. Right. I mean, I really wish I could just do it all over again and start now, because this is the time that I think we're going to see more and more and more breakthroughs in psychiatry, and it's, to me, incredibly exciting.
Dr. Krystal, thank you very much for your time, for everything. It was my honor to host you. And pleasure, and thank you so much.
Pleasure.
Thank you.